Sorry, I'm talking about after people have been diagnosed with breast cancer and are then followed up. And this is a familiar theme that's emerging, that a lot of money is being spent, a lot of time is being spent in secondary care on people being followed up for cancer. And is it appropriate? Why are we doing it? And is it really worthwhile for patients and for accountants? Well, the general impression is that we're going to make everybody live longer as a result of our skills. But the trouble is that when you look into it, most people who have a problem present in between their scheduled visits. They're rarely detected by the peripatetic SHO who happens to be in the clinic that week. And by and large, intensive follow-up and use of investigations don't seem to find metastatic disease very much earlier. And as currently in breast cancer, metastatic disease is generally regarded as incurable and treatment only aimed at symptoms, so that perhaps earlier detection isn't that relevant. So if it's not happening in secondary care, then what about primary care? Well, the real difference is if it doesn't work in secondary care, why is it going to be any better in primary care? Well, some of it is improved patient satisfaction, particularly from continuity of care, but again, most recurrences detected by patients become aware of problems rather than on a routine examination. And so rather than just transferring the workload from secondary care to primary care, people have looked at this differently. And from Hillingdon, Jane Marr, came this concept of if doctors aren't very good at doing it, and there is other research showing practice nurses aren't very good at doing it, or specialist nurses aren't very good at doing it, what about the patients following themselves up? And the way that this is now being put in place across the whole of South London and around the country is patients have a sign-off interview after completing their initial treatment for breast cancer. We agree a care plan, we tell them what to look out for, we talk to them about their drugs, we give them information, and we tell them you don't get a routine appointment for anything apart from a mammogram, but what you do is you have the phone number of the breast care nurse, and we'll see you straight back in the clinic if you've got any worries. Screening mammography continues. So, out in the community is a group of patients who've had breast cancer, who are anxious, who've, if you had a little bit of a block put up, that unless they've got these specific symptoms, which are manifestations of either local recurrence or breast cancer, which tends to spread to brain, bone, lung, or liver, unless they've got any of those symptoms, perhaps they're going to go to primary care to seek reassurance. When you look at whether this technique is appropriate, successful, there still seems to be a fair number of people who remain anxious with it. So the reason for my talk today, apart from your request, was that I felt it would be useful just to run over a few of the things that you might be being presented with more frequently than you were in the past, and that you might feel that you had to have responsibility for now. So patients get information, GPs get information about this process, but my concerns are that aspects relating to adjuvant therapies and menopausal symptoms in patients with breast cancer, and also the risk of swollen arm, or the management of swollen arm, the things that you're going to encounter. So probably I think in general practice, tamoxifen's been around since 1973, and you're relatively familiar with it. What's more recent, I suppose, over the last 5 to 10 years, is the increased use of aromatase inhibitors, such as anastrozole, Arimidex, which block the conversion of androgens or cholesterol into estrogens and seem to be very successful in reducing the risk of recurrence of cancer. So, sorry about the out of focus slide, but you can see that the difference is a substantial percentage here, 15-16%, in reduction of recurrence against tamoxifen. So a more effective drug than tamoxifen, 10 times the price, and therefore tends to be used for people at higher risk. The concern about it is this graph, which shows the risk of fracture. Here's fracture in grey for tamoxifen, here's fracture in purple for Arimidex. So an increased risk of fracture, which goes along with our prejudice that estrogen has been protecting the bone and that taking it away, reducing it close to zero, is going to mean that you're going to break something. And therefore, good practice is to keep an eye on bone density. There are some complex algorithms which are, I think, in what will be emailed to you, which really perhaps you don't need to worry too much about the detail. What it suggests is that in people starting aromatase inhibitors, that if you do their Dexa within the first 3 months and they've got major problems with a T-score of less than -2, then you need to look into why they've got osteoporosis. In people with osteopenic or normal bone density, then simpler measures and perhaps repeating Dexa scans every 2 years. But a responsibility to be decided in local practice as to whether this is something organised by your breast clinic or whether it's organised in primary care. But prescribing a drug with a known and recognised side effect, we need to accept responsibility for monitoring. That was all I was going to say about bone. Then, hesitantly moving on to the treatment of menopausal symptoms. What can we do about hot flushes? These are people who may have been on hormone replacement therapy, had it taken away when they've had a estrogen receptor positive breast cancer diagnosed, or may develop menopausal symptoms, which seem to be more common in people who are treated for breast cancer. There's the obvious things of lifestyle adaptation. There are simple measures where they're available to you, like acupuncture and CBT, which are supposed to be useful. And magnesium, rather surprisingly, seems to be as effective as most drugs in treatment. I'm, in the interests of time, going to skip through this, but I think all this information is due to be sent to you. Next stage up the line, I think, is drug treatments, and the ones that I think are most commonly used are antidepressants. Paroxetine used to be particularly popular. I think you're probably far more cognizant of the complications that you get with the prescriptions of these types of drugs than I am. By and large, they all have a response rate about 60–65%. So 2 out of 3 people likely to be helped with them. Other drugs that have been used, gabapentin and clonidine, again, all helping about 50–60% reduction in hot flushes. Moving on from that, there's the more contentious areas of using hormones to treat these menopausal symptoms. The ones that appear to be most attractive if you are getting onto that rung of the ladder seem to be the progestins, Megestrol, Acetate, Megestrol, and MPA as an injection, so 20 milligrams orally daily or a single IM dose perhaps every 6 weeks. Again, not effective for everyone. About 8 out of 10 people benefit from this. The concerns, of course, if you start giving people these hormones, are that you might, having heard that being a woman's the biggest risk of getting breast cancer, start giving things that might worsen her prognosis, cause new cancers. I think there is some reassurance in these drugs that they are at different doses used for the treatment of breast cancer. The other thing is that the use as HRT progestogens, as I understand it, is conflicting, with some studies showing a reduction in risk, some studies showing an increase in risk. And these drugs, in the situation we're talking about, are largely used in combination with tamoxifen and aromatase inhibitors. And when it's been studied in that way, there seems to be very little evidence about it actually increasing risk of recurrence of breast cancer. Combination HRT, or estrogen alone, is a very effective way of reducing hot flushes for this group of patients, but real concern that all the studies seem to indicate that you get a higher risk of recurrence. And similarly with tibolone, a synthetic steroid, again in the Liberate trial, a higher risk of recurrence of cancer. So by and large, best avoided unless in extreme cases. A simple measure, however, might be to look at the medication they're giving. The mechanism of hot flushes in people with breast cancer is pretty complex, and some of it may come from the drugs, particularly tamoxifen. And the reason that we generally prescribe 20 milligrams of tamoxifen, I think, is because AstraZeneca, when it was called ICI, thought that would be a good amount to sell. All the evidence really indicates that whether you give 1, 5 or 20 milligrams a day, it probably doesn't make any difference. So for many people who have hot flushes on tamoxifen, you can get a reduction by cutting them down to 10 milligrams a day. And simple, easy, straightforward, non-contentious way of treatment. And seems to increase compliance because there's a number of people out there that studies have shown don't take their tamoxifen as we think they are. So, overall strategy for hot flushes, simple common sense advice. Antidepressant, if you feel happy with that. Halving the tamoxifen dose if they're on it. And you can then move on to Megestrol if you were confident with that approach, or perhaps gabapentin seems to offer a way forward, starting off at about 300 milligrams at night and increasing, if necessary, up to TDS. Vaginal symptoms. Again, a common problem for women who are having their estrogen levels lowered to close to zero by aromatase inhibitors due to changes in vaginal flora, atrophy and pH. Again, reducing quality of life and drug compliance, so helpful to treat. I hadn't realised that simple vaginal lubricants weren't all the same, and that there are different degrees of hyperosmotic strength, which are measured by applying your vaginal lubricant to a slug and measuring how much mucus it produces. And that the commonly used lubricants, the ones that have been studied in breast cancer, seem to be, as I understand it, moderately hyperosmotic, which induce irritation in slugs and increase mucus production. So I'd value the gynecologist's advice as to whether we would be better off moving towards treatment with isoosmotic lubricant. Most of the studies that are published in this area with Replens, which is similar, as I understand it, to KY, seems to work well and initially be as effective as estrogen cream, but doesn't seem to have that ability to control symptoms long term. So, is it safe to give topical estrogens to women with breast cancer? They're very effective in reducing these vaginal symptoms. I think the concern is that you do get a moderate increase in circulating estradiol, and therefore I think it's a thing to approach with caution in people who are receiving aromatase inhibitors, where you're aiming for an estradiol of close to zero. So this is the suggested strategy. Perhaps try a simple lubricant. If that fails, estering of the vaginal estrogen application seems to be perhaps the one that has the lowest amount of circulating estradiol resulting. And Vagifem seems to be popular for patients with tamoxifen. Finally, lymphoedema of the arm. So patients perhaps coming to see you concerned, had axillary surgery, is my arm going to get swollen? A lot of fear, anecdote, etc. Of course, in the surgical side, aim at prevention by doing smaller operations rather than removing all of the armpit nodes. The concept of sentinel node biopsy you're probably familiar with, which is an injection of a marker into the breast, and hopefully the colloid trace of radioactivity or blue dye gets taken along the same pathway that any tumour cells would take. so that when you operate on the patient, you stick your nuclear medicine probe in, find the hot node, which hopefully is also stained blue by the blue dye you've injected. And if that node is clear, then hopefully you can save the patient the additional complications that go with a full axillary clearance. The rate of lymphedema in full axillary clearance is of the order of about 40%. With sentinel node biopsy, it's 5%. So even with a small operation, it doesn't mean you're immune to problems. So what can patients do afterwards? Well, there's a lot of myth, anecdote about it, all of this, of course. And one of the things has been avoid overuse of your arm. It's not really been studied very well. There is one trial out there from JAMA, so a reputable journal, where they randomized people to an exercise regime, lifting weights or not. And actually, when you lifted weights, you did better and had less lymphedema, 17% in those not lifting weights as part of a scheduled exercise program, and 11% if they exercise. And again, greater than 5 lymph nodes removed, 22% of the patients in this study lymphedema, which went down to 7% when they exercised. I think there has to be a degree of caution in this. The weights that were used in this study seem to be relatively modest, so I don't think it's encouraging power lifting, but the occasional use of the iron might not be as hazardous as we thought it was. Can you fly with lymphedema? I think it's a bit like that myth that women think their breast implants are going to explode as they take off. Actually, flying doesn't seem to do very much when you measure the arm. And the concept, I think some women might approach you saying, you know, I'm going to fly, I'm worried about this. Can I have one of these supporting sleeves just for the journey? In fact, the studies that have been done actually show it's counterproductive. So it's safe to fly after armpit surgery. What about having bloods taken? Well, I think there still remains concern that this may be a hazardous thing, introduction of infection. Probably in some people does precipitate lymphedema, so avoid if possible, try and use the other arm if practical. But if you're forced to, don't worry about it. Can you shave your armpit if you've had axillary surgery? Yes. No data to suggest a risk. What about having your carpal tunnel operated on? Yes. No great increase in risk. What about diet? Being overweight is a dreadful thing. I find this actually, I'm not sure about cosmetic consultations, telling people to lose weight when they've got cancer, I find the hardest. It's bad enough getting cancer without being told you're fat. And so being overweight increases your risk of recurrence of breast cancer, increases your rate of getting it in the first place, it increases your risk of lymphedema. If you can lose weight, then there's a good chance that you will also reduce your chance of getting lymphedema. So to be encouraged if possible. It doesn't seem to matter whether you lose this weight by Atkins or whatever other means. There is no data on whether cutting down your dietary salt helps. So from secondary care to primary care, thank you for your attention. I'm conscious I've spoken about things gynecological, and I wouldn't be surprised if you would prefer a third opinion on those from my colleagues. Thank you.